Good morning. Thank you very much for being here. I'm going to review the strategies used for self-management of bowel symptoms and highlight the evidence behind them, and then close with some recommendations. So more than 2/3 of adults with fecal incontinence or accidental bowel leakage use some self-care practices. Things like wearing a pad or a panty liner, taking antidiarrheal medications, changing diet, performing pelvic floor muscle exercises or self-biofeedback, decreasing activity or exercise if those are triggers, skipping meals, taking special preparations. So people are doing things that are considered self-management. And when I think about self-management of ABL, I think about it in sort of three clumps of things. There are the dietary and bowel-related modifications that people can make. There are the pelvic floor muscle exercises and home biofeedback or e-stim. And then there are the containment activity modifications. And so, as you just heard from Dr. Tannenbaum, self-management is when a patient identifies a problem, and then with help from you, she identifies evidence-based solutions and picks which ones she's going to adopt for herself. Unfortunately, when it comes to self-management of bowel symptoms, we're really lacking in evidence. So let me tell you what limited information we do know. And I'm going to start with the dietary bowel-related modifications. Avoidance of triggers, just like with bladder and self-management of urinary incontinence, can be helpful for patients, and it's a very commonly cited coping mechanism and self-management strategy that people with ABL use. There are no randomized controlled trials. There is not level 1 evidence the same way that we do have for avoiding caffeine for bladder symptoms, but there's also no level 1 evidence to support parachutes, and we still use them. None of us would jump out of a plane without them. So if a patient tells you, well, every time I have dairy products, I'm going to have an accident, then avoiding dairy products is a reasonable self-management strategy for her, and that's actually part of the value of the bowel diary, the self-monitoring, to identify triggers and things that then to improve success, for them to recognize their improved success with modifying those triggers. Optimizing stool consistency is important for self-management of accidental bowel leakage. And I really make all of my patients complete the Bristol stool chart because it gives me a sense of where they are on the spectrum. Types 1 and 2 are the most constipated. Types 6 and 7 are essentially liquid stools. And the easiest stools to hold onto and evacuate are types 3 and 4. So a patient who is constipated needs a regimen to promote rectal evacuation and pull water into her stool, whereas a patient whose stools are too loose needs a regimen to bulk stool and decrease the rate of transit. And those goals can be achieved through dietary modifications or medications. Fiber supplementation is one of the things that we do have good evidence for, and there are lots of theories about why it helps. There are two kinds of fiber. Insoluble fiber results in stool bulking, water holding, and gelling consistency to help the stools stick together. Soluble fiber gets metabolized to short-chain fatty acids, which promote colonic water absorption and cell metabolism. And most fiber-containing foods actually contain both kinds of fiber. The theories behind why fiber may help with self-management are that fiber can increase rectal distension, which then leads to increased sensory awareness when there's delivery of stool to the rectum. It can reduce liquidity of stools, and it can also facilitate more complete rectal evacuation. And, oh no. In a double-blind, placebo-controlled, randomized controlled trial comparing 3 different fiber supplements, psyllium, gum arabic, and carboxymethylcellulose, where each person took in a total of 16 grams of fiber per day for about a month, the most significant improvement was in fiber supplementation with psyllium, where the number of episodes went from 6 a week in the placebo group to 2 a week in the group that supplemented with psyllium. And additionally, psyllium was the only fiber supplement that resulted in a gelling consistency in the stool. So there is good evidence to support the recommendation of fiber supplementation with psyllium for patients with accidental bowel leakage. And interestingly, in this study, actually carboxymethylcellulose resulted in an increased number of episodes, so probably recommend staying away from that. There are also data to support several medications that can be used for self-management that are available over the counter in the States. Loperamide is one that's used to slow down loose stools. It's an antidiarrheal agent, and it's more effective if ABL is associated with urgency. There was no difference in a randomized controlled trial comparing fiber with loperamide, and loperamide did have more side effects. But for patients who cannot fiber supplement or in whom fiber supplementation doesn't work, loperamide is a good strategy. Polyethylene glycol is used to treat the opposite problem, where somebody's constipated and therefore, because of a full rectum, doesn't have any capacity for storage and therefore has loss. And polyethylene glycol has been demonstrated to be superior to lactulose in terms of the number of stools per week, stool form, and side effects such as abdominal pain and gas. So those are all evidence-based modifications for self-management. In terms of pelvic floor muscle exercises and home biofeedback or eStim, why does it work? Well, it strengthens the external anal sphincter and puborectalis muscles and can improve rectal sensation. There aren't good randomized controlled trials of self-management or doing these exercises unsupervised, but if a patient perceives an improvement, then why not? And finally, activity modifications and containment in skincare. Avoiding triggers, maintaining a bowel routine, and preparing can give patients peace of mind, bringing things like a change of clothes, moist wipes, a pad or body liner, and a plastic baggie, so if there's an accident, they can put their clothes away. I tell all my patients, your bottom is just as sensitive as it was when you were a baby. Think about how you would treat a baby's bottom. You need to use a barrier cream if you're having accidents. There are a couple of very promising continence devices that are on the market now that still need to be prescribed at this point, but are really changing the game in terms of self-management. One of them is a rectal insert, sort of similar to the older anal plugs, but this is not absorbent. It's made of a flexible silicone, so it can be inserted into the rectum, prevent stool leakage, and then when a patient wants to have a bowel movement, they just defecate this out and it can be flushed in the toilet. In the first trial of this product, people went from having 6 episodes per week to 1 episode per week at 3 months. Similarly, there's actually a pessary to treat fecal incontinence. It sits in the vagina and has a balloon that inflates posteriorly to occlude the rectum. And that was associated with similar improvement from 6 episodes a week to 1 episode per week at 1 month. Both of these self-management devices have no adverse side effects. So these are sort of new and upcoming and are things that can really empower patients with ABL to self-manage. In conclusion, symptom tracking enables self-directed, personalized effort and evaluation of results. There's good evidence to support the use of psyllium. There are some promising devices, but they lack control groups. And there's little evidence for other self-management strategies, so any budding researchers in the audience who are interested in putting some evidence behind these recommendations, I welcome you to contact me to collaborate. Thank you very much for your attention.
Thank you very much, Dr. Brown.